Good morning, everybody. Dr. Gabriele Jasper, MD, interventional pain physician with Jeremy on Painless
That's
with Dr.
right.
Jasper. Well, that's what I am, an interventional pain physician.
Yep.
And like I said, I always want to talk about what that is in the beginning, just in case by any chance somebody new's on board here is just wondering who we are. Well, interventional pain physician, in my opinion, is a physician who gets rid of pain by trying to find out where the pain source is, the actual pain generator.
Mm.
And when we find it, we get rid of that pain generator, and miraculously, the pain goes away.
Yeah.
And it's not always as easy as it sounds, but the majority of the patients, you can find it if you're looking for it.
Yeah.
There's some people don't even look for it. But that's what we do. We do it by different ways, conservatively and minimally invasively. But no invasive procedure in the Jasper Spine Institute.
Mm.
We do a minimally invasive, non-invasive procedures. And we do procedures.
Yeah.
We don't treat people with narcotics, pain medication, or anything like that. No hocus pocus stuff.
No, you just see your way to getting rid of the pain altogether. That's the
we do stuff like epidurals,
yeah,
ablation of the medial branch nerves for spinal spondylosis, which is a fancy name to say arthritis of the spine.
That's right.
Epidurals for sciatica pain, herniated discs. And if all of that doesn't work, and by the way, there's a lot more than that, we can go to what we call the next step, especially for like spinal stenosis. Spinal stenosis is a type of procedure that, spinal stenosis is a type of disease that if you don't actually treat the spinal stenosis, nothing else is going to work.
Right.
So somebody tells you, if you're out there, you have spinal stenosis and you're getting injections and injections and injections. There is no injection in the world that's going to help you with spinal stenosis.
Right.
If you got mild spinal stenosis, there's a chance you can get an injection, might work for 6 months, a year.
Yeah.
And sometimes that's not a bad thing. And I always say that if you can get an injection once, twice a year, and you're doing good, you have a good quality of life, that's what epidurals are made for.
Yeah. Precisely
what they're made for. They're not a Band-Aid when it comes to that point. And when you have a moderate to severe spinal stenosis, there's no such thing as a Band-Aid, because a Band-Aid at least will cover something up a little bit. But you get an injection with moderate to severe spinal stenosis, it ain't going anywhere.
Yeah.
It might work for 1 or 2 days, a week, if you're lucky, and then it go right back the way it was. You people out there that have been treating or being treated right now, we have a few things that up our sleeve that could really get rid of this spinal stenosis. And by the way, now that we're on the subject, this morning we didn't know exactly what we want to talk about, but spinal stenosis is always a good topic.
Oh yeah.
Yeah. And you can have it in the cervical spine, thoracic spine, and lumbar spine. But the easiest to treat is one in the lumbar spine, because every time you turn around, every 6 months, something new's coming out, minimally invasively or non-invasive, which will open up the canal. It's a person who can't stand for a long period of time, sometimes not even for a short period of time, depending how severe it is. They can't walk. They can't walk without having to stop and sit down. Sometimes if there's nowhere to sit down, they got to lean over on a tree or just lean over.
Yeah.
Sometimes squat, if your legs are strong enough, but, most of them legs aren't strong enough. Once you squat, you can't get up.
Yeah.
So it's weakness of the legs.
And you're wishing you didn't go out in the first place.
Well, yeah. I mean, also people lean on the shopping cart syndrome, I call it.
Yep.
And walkers, these are the people with walkers.
Yeah.
That, you're leaning forward. When you lean forward, somehow that makes you, I could tell you the physiology behind it, anatomy behind it, but I need visual aids. But trust me, it's standing up straight, very difficult. And what did you just say that you brought up a subject that I wanted to go into, spinal stenosis, and I was going to say it about who knows?
Yeah, who knows now, right? Yeah.
I should have, but I just want to get that in there about the shopping cart and leaning forward. You said something about, and they can't. Well, anyway.
Oh yeah, and they wish they hadn't gone out in the first place.
That's a good point. With spinal stenosis, people a lot of times are out of shape,
right?
And their legs are very, very weak. Why? Because number one, they can't walk.
Yeah.
Why? Because it hurts. So if you can't walk, it hurts. You don't want to walk.
Right.
So you don't want to go out. All of a sudden, things that are not that far away become very, very far.
Right.
Like,
Yeah.
a bathroom at the end of the hallway.
Yeah.
That becomes extremely far for some people. And I remember one of the first times I did these procedures, the posterior interspinal spacer, they call it fusion, but it's really not, to the fusion that we know of. It's not the rods and the screws, but we got to call it fusion to bill it, and it's a form of fusion.
Yeah.
But it's kind of a stigma, that word fusion, so you got to be careful how you use it. But I put one in somebody, and he got up and he started walking around and showing me how good he was immediately post-op before he went home.
Huh.
And he looked and he says, "I got to go to the bathroom." And he looked across the hallway. He says, all of a sudden that bathroom does not look so far
away. Yeah.
And that's it's what it is.
If you have spinal stenosis, I remember when I was at the top of my pain, and I would have to plan in my mind. If I was getting up, I'd have to plan like you're planning a trip, oh, okay, I got to get up, I got to walk over there, and you're trying to build it up, and then you go, because it's an undertaking, especially when that pain just comes at you, and it's coming. As soon as you stand, it's going to start coming, and
I'm sure a lot of people out there right now could relate to this.
Yeah, totally.
Especially if you listen to this and you do have pain. It's not fun. It's not fun when you got to go somewhere.
Yeah.
But and that's spinal stenosis of the lumbar spine. I had a patient yesterday that we did a bunch of procedures on him. He's from Africa. Nice guy. I really want to help this guy, but he's got moderate to severe spinal stenosis of the lumbar spine. I gave him some epidurals, didn't work. I did, of course, I did this way in the beginning before I really knew much about how you can't treat anything until you actually treat the spinal stenosis. I did the radio frequency lesioning ablation, nothing worked. And I finally put a spacer in him to open it up. And it worked to a certain extent, but not as much as I would expect.
Right.
And he's in there complaining about, loss of balance. He's got to use the walker, the cane, starting not to be able to use a cane. This is after treating him. Yeah. What's the first thing you got to suspect now? The man has spinal stenosis of the lumbar spine. It didn't really get that much better with treating the spinal stenosis of the lumbar spine. He doesn't have neck pain. He doesn't have pain going down into his arms. So you don't think about getting an MRI of the cervical spine until you start to hear these symptoms and they're not responding as well as you would think that they should be when you're treating the lumbar spine. I bet you, I just had him the other day and I sent him out for a new MRI of the cervical spine. I bet you he's got at least moderate cervical stenosis. And I think we talked about this a couple of weeks ago. And I want to bring it up again. When you have cervical spine stenosis, that needs to be opened up. And most of the time it needs to be opened up surgically.
Yeah.
And I'm a strong advocate in treating the lumbar spine as much as you can with lumbar decompressions that are minimally invasive.
Right.
And they're out there. But for some reason, I don't know why, but they have not invented, or I don't know anything that's invented. If anybody's listening and they have something that minimally invasive to decrease the central canal stenosis of the cervical spine, let me know.
Yeah, right.
Because there are certain patients that have or respond to a cervical epidural that have moderate central canal stenosis. That's providing they don't have any abnormalities of their spinal cord. But I've had people with some slight abnormalities of the spinal cord, and at that point, you have to bring a neuro or an orthopedic spine surgeon in the loop,
right?
Because there is so much pressure on the spinal cord that you're killing some of the nerves, and you'll have permanent damage if you wait too long. But what I do is I also do a cervical epidural below the fusion, below the stenosis, never above or at the level of the stenosis. You got to be very careful. And I've had reversal of these central canal, of the spinal cord lesions, as they call it, not lesions, but changes from ischemia, from too much pressure on it. Why? Because the nerves are swollen, inflammation, and when you give them a shot of steroid, it decreases the inflammation and the pressure comes off it, and they heal up,
Right.
providing it just happened. But when they go to the surgeon's going to tell them, what we're going to do is we have to do surgery to decompress it, probably take some bones out that are surrounding the spinal cord. And and what they usually say is, we're going to try to reverse this to make you better. But the main thing is to prevent it from getting worse. That's your classical, talk with the surgeons. And I'd say the same thing. When somebody has foot drop and they come to my office, sure enough, it's something putting pressure on that nerve.
Right.
And we have to find out what it is. We do an MRI, we see it. And if it is a foot drop, there's no, you do maybe an epidural real quick, just to calm down the inflammation. And a lot of times it goes away, the foot drop gets better because everything shrinks, the pressure's down, and it heals up. But that doesn't mean that it's going to go away forever.
Right.
Most of the time, you got to go in there and find out what the cause is. The cause, it could be a herniated disc, most likely,
right,
or it could be severe spinal stenosis. But that's a problem. I had another patient that came in the beginning of the week. I've been treating, doing real well, nice lady, a couple epidurals. She probably needs a spacer. However, she's doing good without it. She came in on Monday, I think it was, and said, "Doc, it seems I almost tripped because it seems like I'm dragging my foot."
Right.
And when I had her dorsal flex it, put her hands up, like feet up like this, dorsal flex it, and the one on the left side only went halfway. And it was weak. Like if you put pressure on it, she couldn't lift her toe up against and I wasn't even pushing down. I was just holding it there.
Right.
Against my resistance. She couldn't lift it up. So that's partial foot drop. She was moving it. First thing I did an MRI. She finally came back yesterday. She got a new herniation that wasn't there initially. So somewhere along the line between when I started treating her and now, she had what they call an acute disc, a new herniation.
Right.
So I never injected around that area. We're gonna give it a shot on Tuesday, and hopefully it'll clear it up. That might have been there even before I started treating her, but happened after the last MRI, which is probably about 8-9 months ago.
Right.
If it doesn't clear up right away after, or show improvement of strengthening after the epidural, then we have to go in there and open it up and take out that herniation. And I do it with very, very small incisions for that's my endoscopic surgery that nobody wants to pay for.
Yeah.
But I do it. I don't get paid much, but it's tough. It's tough doing these procedures. I learned how to do it years ago, and I'm pretty good at it. So it's not as stressful for me than somebody who's just learned it.
Right.
And nobody wants to learn it because nobody's getting paid for it. I have another patient, I think I talked about him, that had laminectomy throughout the whole spine.
Oh.
And he's got and he's crunched over. He's around my age, but in great shape. But he can't even move. He's like twitchy, moving.
So he's
around.
got a scar all the way up his back.
Yeah.
Yeah.
But now what happens is the neuroforamina, where the nerves come out, are breaking down and crushing the nerves. Now he's got severe pain down his legs.
Right.
I used to do endoscopic surgery for it when we got paid for it.
Right.
And I do each level one at a time because you can't do it all at the same time. And sometimes you don't need to do it all. You pick the ones that you think is causing the weakness or the sciatica pain, and you open it up.
Right.
You get rid of 50% of it, then you go to the next level, which was good when it was getting paid for. But now it isn't getting paid for. So the patient has to actually pay some money out of their pocket. And he was willing, and we talked about that. He was willing to pay. He says, "I don't care," because he's relatively young. He's in good shape, and he's incapacitated. So I'd pay anything for that. But and I don't charge a lot of money for it. I probably should charge more because of the risks of doing that kind of procedure, especially at that level with the scar tissue and the bone spurs, osteophytes, everything digging into the nerves. And in fact, he's already compromised. And after, how much better is he going to get?
Right.
After all of that. But we'll see. It's hard for me to say, to abandon somebody like that. It's not my nature.
No.
But I'm going to give it a shot, even though you just have to pace yourself.
Yeah.
Prepare yourself mentally for these kind of surgeries and just go in and do it. But
I think I saw that woman that had was dragging her foot and stuff.
which one? I don't know.
I think she was.
It might have been Wednesday.
It might have been Wednesday
Might have
because
been
she was
Wednesday.
a little short, blonde hair. She recognized me because I had sat and spoke with her before, and so she was like, her eyes were bulging, trying to get my attention. And
Really?
yeah, I happened to be behind the counter, and she's like, "Hi," and I'm like, "Hi, how you doing?" And she says, "Oh no, I'm good. I'm I have this little problem, but everything's going great with Dr. Jasper." And I'm like, "Yeah, you got to stick with him, and you're gonna get through this." But she seemed very hopeful, even though she was describing exactly what you said, how she's dragging her foot, and that. And I says, "Well, that might be a type of foot drop or something like that." Yeah, I says, "But Doc'll take a look at that." And
she didn't seem fazed by it.
No, see, that's
Right
the
away,
thing.
she was like, "Well, I heard there's some kind of foot brace that you can use." I think her daughter was there too. We were talking about it, and I told her online where to get them. There's a lot of foot braces are very cumbersome. They're so cumbersome for foot drop that they don't want to wear them, and then they start tripping all over the place.
Right.
But I saw a couple of them online that are pretty nice. Very simple, like a Velcro, just strap and hook it onto your shoelace type thing. But she should do good. It's a sudden onset. Hopefully by Tuesday, after I give it a shot, that a lot of times in the recovery room, they're already moving it better.
Yeah.
But like I said, you can't waste time. It's not emergency, but you don't want to waste time.
Right.
You want to get in there as soon as you can. Didn't you had that, right?
I had that. Yeah.
That's exactly what happened to you. And we had no anesthesiologist. We had to do you awake,
Right.
completely awake.
Right. Right. It was really bad. And people marvel at that. You went through a surgery like that when you were awake. And I says, yeah, but I mean, it's a testimony to the doc.
And the foot drop came right back, right?
Yeah. It stopped right immediately, and I came.
If we would have waited another week, chances are you would have still had foot drop.
Yeah. In fact, it was so quickly. Once I got off the table, it's almost like you forget.
Yeah.
Like you forget that it was even an issue to begin with, because I don't remember the feeling good about it. I just remember feeling good about it. Yeah.
And people should be aware of foot drop, because this lady didn't even know what it was.
Oh yeah. I face planted when I could, because you're unsure with your footing.
Well, what happens is you can't lift your foot up.
Yeah.
When you walk, your foot naturally goes up and it goes down.
Right.
When you walk, you lift it up so it doesn't drag your toe.
Yeah.
Part of the symptoms of the beginning of foot drop is your foot starts to slap.
Yeah.
You get one foot slapping as you lay it down, because it just it gets weak.
Right.
And you hit your heel and the toe slaps. So if anybody has that, don't be walking around with it. You could fall, trip, and possibly we could fix it.
We say all the time on the show, don't I mean, I know I lived with pain a long time. You get complacent with it. It's the one thing you can trust, because you're guaranteed that a lot of them stay the same or get worse, and you know that for a fact. And somehow, in a weird way, you get complacent with your pain. But that's why you have to rush to a good doctor like Dr. Jasper here, because the longer that lasts, the more damage could happen. You don't know. So it's good to get into the Jasper Spine Institute. 732-262-0700 if you want to make an appointment with Dr. Jasper, and he'll see you through it, man. He saw me through it. And I always tell our patients that, the new patients, when I sit with them, you've been looking for a doctor. Sit with this one through your treatment. There we go.
we talked about how you did that anesthesia. You did
Yeah.
that surgery. We did the surgery on you without anesthesia. That's a pretty good topic, which I discussed this morning with Rosalind about things we should talk about because she remembered an incident that we had Tuesday where somebody told a lady, or at least she said somebody told her that she's getting anesthesia. She requested anesthesia. We do great anesthesia in our surgery center, except there's laws by the American Society of Anesthesia, the anesthesia societies. They come out with these rules and to be safe.
Right.
As far as NPO status, no, it's not going without eating or drinking for a certain period of time before anesthesia. Now, I know some places will say 6 hours for solid food, and you could drink water for 4 hours, up to 4 hours. But most surgery centers, and it might be a state rule or federal, who the heck knows, but usually it's the anesthesiologist's discretion, and they come up with the rules. In our surgery center, I think it's 8 hours. You can't have solid foods, and you have to have within the 8 hours. Well, no shorter than 8 hours. You can have your medication. Like when you get up in the morning, let's say, and you got like maybe 6 hours left, you can have medication with a sip of water. But this one particular patient came in and she thought it was 6 hours, and she had milk and cereal, right? And we had to cancel it.
Right.
But we didn't cancel it because of the fact that it wasn't actually 6 hours, because she was 6 hours before she had her appointment. But her appointment usually goes for about an hour and a half or so. So it was an hour and a half more. So it was like 7.5 hours. So we just, to be safe, we waited an extra half hour. We did the anesthesia. She turned out okay.
Right.
But people don't understand. It's not just a rule for no reason.
Right.
Because what happens if you still have food in your stomach and you're asleep, you can't protect your airway. If you regurgitate, vomit, where's that going to go? Sometimes it's directly into your lungs.
Oh, Jesus
And
Christ.
if it goes directly into your lungs, you got dirty food, you got bacteria, you got all acid coming from your stomach. That could kill you. That's aspiration pneumonia, which is a high fatality rate.
Right.
If you don't treat it right.
And you get a form that you sign like before for all that, right? Warning the people of all the
that could be a complication.
Yeah.
And it could happen even if you did go. Some people have food in their stomach for 12 hours.
Right.
Usually after 8 hours, it's gone.
Yeah.
But that's a bad consequences, and people don't realize it. The lady got so upset. She said, "I'm never coming back here again. You guys are all effed up." It came out with all, in which somebody told me 6 hours, and I'm sure nobody told her 6 hours. I mean, we've been doing it so long. Yeah. The lady that talks to them about it doesn't say 6 hours.
Right.
But either way, to give everybody the benefit of the doubt, who knows? Maybe somebody new said 6 hours. I don't know. But the point is, we're doing it for their health. There's no reason to get mad, but thank God we came up with a remedy. She kind of got mad that we had to wait, but
you had to be sure.
Yeah, you just can't. It is what it is.
It's that was for the patient's best interest. That's why that was done. You can't get angry at that. I mean, somebody looking out for your life.
Yeah, they do. But now talk about different types of anesthesia.
Sure.
That we do at the surgery center, at the Jasper Ambulatory Care Center. We have board certified anesthesiologists. Right? Very good anesthesiologists, very, very seasoned and experienced and safe. Now, we could do anesthesia anywhere from what they call conscious sedation,
right,
which you're awake. And it's a good chance you can remember everything, but you're relaxed. We give different types of medication for conscious sedation. We give a medication for anxiety, right, and that's the main problem. People are anxious for these procedures. And we give medication for memory, amnesia. So even if you don't have anxiety, chances are you're not going to remember it.
Right.
Right. It depends on how much we give.
Yeah.
And also we give medications for pain. which are narcotics. And some of the narcotics are being abused on the streets today. But it's done under a controlled environment. You have oxygen. You have vital signs taken. We take our blood pressure, EKG, also the pulse oximetry. We know exactly how much oxygen you're saturating in your blood.
Right.
And it's done by a board-certified anesthesiologist and or an experienced nurse that is credentialed and trained in conscious sedation. But they have to do that under the doctor's supervision, which we do. Rarely we do that, but we prefer to have an anesthesiologist, and so would the nurse. But we do have nurses there that can do that, but that's very rare. That's the lowest form of anesthesia. But you got to remember, they train anesthesiologists that a patient has to be healthy enough to be able to undergo general anesthesia. As soon as you say this patient's going to have conscious sedation, you have to be prepared to possibly do general anesthesia.
Right.
Whether it's because the patient had a reaction to a medication, the patient just lost their airway, patient aspirates, right? Or something happens in the operating room where you need to put them under general anesthesia. So that's the standard rule. I don't even know if that rule changed, but when I was trained, when you go in, even a person who's going to get 1 milligram of a medication that just takes away a little bit of anxiety, they got to be well prepared as far as, they can't have bad heart disease, lung disease,
Right.
bad anything. It has to be an ASA2, which is a patient in pretty good shape to do it in the surgery center. You could do surgery on these patients, but it has to be done in an environment like the hospital, where you have the ability to treat something immediately. For example, something happens in the OR, you bring them to the intensive care unit, and treat them.
Yeah.
And there's staff there to do it. Yeah. If they do this in the surgery center, the patient has to be transferred to the hospital. So you're losing precious time, even though you're in an environment with multiple anesthesiologists and nurses, and we're there with the proper medication if God forbid there is an emergency. And we have had emergencies and we've successfully treated it.
Right.
Because we're very experienced.
Oh yeah.
Everybody, especially anesthesiologists, are intensivists. They've worked sometime or another in the cardiac unit, in the ICU, surgical ICU, intensive care unit. And the nurses also, all the nurses in my place have had extensive training and experience in the hospital. So we're prepared for anything there. And then what's the next step? The next step is anesthesia, where it's more than just conscious sedation. You're actually put under with medication known as propofol. And that's your typical, people know that this is what they give you when you have a colonoscopy.
Right.
You go in for the colonoscopy, you lay down a little bit on your side, and they give you the medication. Next thing you know, you're in the recovery room. And certain procedures that we do in the surgery center, it's the same thing. And then now we've been doing some more intense cases where you actually need the patient to be paralyzed, intubated, and on a respirator. And we do that too. I do that.
Yeah.
This is some of the things that I do. I got a lot of training in that, and I had a lot of experience. But so that's it, from one extreme to the other. So don't drink or eat. That's probably the whole topic of this conversation.
Right.
Within 8 hours of the procedure.
Yeah.
Because chances are they're going to cancel it for your benefit. Yeah. Aspiration pneumonia is not a good thing.
Doctors don't tell you stuff for no reason, They tell you this stuff, because there are precautions, and you got to be smart enough to take, your doctor's advice. All right.
All righty. So that's we covered a couple of topics today.
We got Eileen. She says, "Hi, Dr. Jasper." Hi, Eileen. How you doing?
Nice picture, Eileen. You look awfully young in that.
You do. You do. Yeah. God bless you. Look at that.
All righty.
He's a cute kid, though. I'll tell you that.
We have a couple new procedures coming up, believe it or not.
Do we really?
Yep. We have this, and I think I talked about this too. when you look at an MRI, you notice things.
Mm.
I've been looking at MRIs and reading it for such a long time, and I noticed over the years that around the end plates of a disc, when somebody has degenerative disc disease, you think it's just breaking down, which it is. Most of the time, it doesn't cause much pain. But then, if you look at the MRI, you could see what they call modic changes, which is kind of a white and a certain type of MRI. It's called the T2 weighted. You can see along the dark line where the disc was or still is a white blotchy thing that kind of comes out of it.
Right.
They call it modic changes. I always considered that to be a painful process. But years ago, we talked about it at conferences, and it was probably 50-50, maybe more, like 75 said that it's not painful.
All
And then
right.
you had 25%, including myself, saying it's painful.
Yeah.
All of a sudden, after 27 years of doing this, they're coming out this year or last year to prove that it is painful. And the way they do it is in the vertebral body, which is the bone in the spine, the
Right.
big, thick bone that sometimes breaks, becomes compression fracture. That bone has this nerve called the basal vertebral nerve. It's not a big nerve, and it's not a nerve that's insulated and strong, but it's a nerve that brings the pain sensation to your brain if there's any kind of injury or inflammation in that area.
Right.
So they found out to prove that these changes that you see on the MRI, especially in patients that had everything done to them and still have low back pain, they've gone in there with, like they do the ablation of the medial branch nerves for the arthritis. They've gone in there with these probes that give out radio frequency energy and heat up the nerves. And when you heat the nerves up, it stops them from working. And they found a very good success rate, statistically significant, as they say,
Really?
which means that it's valid.
Sure.
So my theory all along has been true, that the pain is coming from these modic changes, or these, they call them schmores nodes, which is the crevices that you see going into the vertebral body. I mean, things don't erode into a bone that has sensory nerves without pain.
Right.
It's common sense. And when you stick these electrodes in there with radio frequency, bipolar or whatever it is, and you heat it up, and the pain goes away. So I'm going away. The procedure is the exact same procedure you do a vertebroplasty or a kyphoplasty. Oh, same procedure, except you're using energy, not putting in cement or epoxy.
Right.
So in order to do this, you got to get certified. So I'm going to get certified by the company that's going to send me to Boston at the end of the month, March. I think it's the 24th, for 1-day course to get certified. And it's basically a medical legal thing where you got to do you put that certification on the wall, and then all of a sudden you're good.
Right. Right.
They talk about weekend courses.
And you're just adding more to your tool house.
Well, you talk about weekend courses.
Yeah.
Right. This doctor, all he did was a weekend course, and he thinks he's an expert. You ever hear that one before?
Yeah.
He takes weekend courses. That's what they do. But guess what? When you graduate from your residency, you graduate for your fellowship training. Now, this is a medical legal topic right now.
Right.
When you graduate, what do you learn? The future that has not been invented yet.
Right.
When I graduated from my residency, we'd have 1/8 of what we have today. We didn't have it. So where are you going to learn it? You're going to learn it at weekend courses. And when I say weekend courses, sometimes they're a week long, and sometimes they're 1 day. Sometimes they're a half a day. Why? Because medically, legally, you got to get a certificate.
Yeah.
Some of these things are so simple, especially somebody's got my experience to learn. You can learn it in the kitchen table in my office,
right,
on a dummy. Now, I'm not talking about a live dummy.
No.
I'm talking about a But they're very easy to do because, like I said, I've done thousands and thousands of kyphoplasties and vertebroplasties.
Yeah.
Same procedure. What do I got to go over there and learn how to do it for?
Right.
Because God forbid something happens, which no matter what you do, even if you do it the right way, by the book, you're very cautious, very specific, very selective. I mean, you can come up with all kinds of synonyms, and something still could go wrong. They call that a complication.
Yeah.
A complication, no matter how good you are, no matter how good you do it, could still happen. And most of the time when it happens from unknown reasons, we're human beings, and not that the doctor's a human being, that he made a mistake, but you're working on human beings. Everybody reacts differently
Right.
than the other person. So if you don't take these courses, you don't get certified, you're basically crucified on a witness stand or
Yeah.
in the court of law,
Right.
and then they tear you apart. So that's a little bit of medical legal stuff. But anyway, there's good stuff coming out. And that's the latest. And we got another one that's coming out. I'm not mentioning it right now because I'm not pushing any kind of because there's more than one.
Because when you're looking for new stuff, I mean, it ain't new until you've vetted it out as best you can, so that this is good for your patients and nothing bad.
Listen, I'm learning how to do it.
Yeah.
In theory, and not only in theory, in my theory, right?
Yeah.
But statistically, it works. They've done studies. They don't just, the FDA just doesn't like, oh, yeah, good idea.
Yeah.
All right, let's sell it and try it on patients. No, they go through. That's why sometimes it's very expensive to buy the instruments.
Right.
Because you're not paying for an instrument that might cost $5.
Right. Yeah.
You're not paying $6,000 for something that you need to use because it costs $6,000. No, what you're usually paying for is the fact it took them 5 years and millions and maybe billions of dollars to get it to the market.
Right.
So they're doing a little catch up because they probably borrowed a lot of money to get that. That's stepping out.
You're buying the knowledge, all the people that put their brains to it. All that time is money.
See, this is the things that people don't understand, why certain things are expensive. Hey, quite frankly, I don't understand why they charge you so much.
Right.
A lot of times they charge you more money than the facility actually will net.
Right.
So they're making more money than the facility and the doctor put together, who's taking all the risks at this point.
Right.
They're all lawyered up for
Sure.
years, and they got a lot of protection. But we're like measly old doctors with no money to pay lawyers.
Shabby old doctors.
But there's another one that they use like an allograft, they call it. Allo, like a graft that, in other words, the disc material, which is a nucleus pulposa, right? It's the center of the disc, and this nucleus is what causes a shock absorber effect of your disc. Right. Your disc, as you're walking, it's a shock absorber. You have what they call as an annulus, and inside that annulus is the nucleus pulposa, which is it's designed, by whom miraculously it's designed so it's a good shock absorber. But what happens when you start to get degenerative disc disease, which some people have it genetically,
right?
And I've seen patients with degenerative disc disease at not even 30 years old, 28 years old, and that's a problem. It's genetics.
So I jump off a curb, feet plant down on the ground. That nucleus is providing the
shock absorber.
As
you're walking down the street, standing up in a train while it's bumping,
Right.
But now they came out with kind of a graft that they get from cadavers, and they take out fresh nucleus pulposa and they treat it so that when you put it into a patient's disc, that's what we're doing. I haven't done it yet.
Right.
But you put it into the disc, and now you're replenishing the shock absorber.
Yeah.
Statistically significantly, it becoming popular because the studies, and they do studies to pass the FDA and to be accepted through the insurance companies to pay for, which this one from what I understand, is.
Hmm.
And this is another new thing coming into the practice.
Wow.
We haven't done it yet, but my favorite thing was when a patient's like, "Doc, what are you going to use me as a guinea pig?" No, it's not as a guinea pig because it's been used. These things have been used on patients and on experiments for years.
Yeah.
Somebody's got to be the first person,
Sure.
and somebody has been the first person. You might be the first person that I do.
At the practice.
Yeah, but I don't do anything unless I know how to do it.
No, this has been tried and true, right?
Yeah, and if you're good, you got good hands. It's not hard to do these things.
Right.
Of course, the more you do, the better you get. But there's not much of a learning curve on most of these things. It's not like endoscopic spine surgery.
No.
That has a learning curve that can last a lifetime.
Right.
I've been doing it for, I think, pushing 18 years now.
Yeah.
And I'm still learning.
Yeah.
I'm learning some patients not to operate on.
No, truth though. Yeah. Yeah, that's amazing. Let me see what we got here. Yeah, but now we were talking about radio frequency ablation earlier, right? And I just wanted to let people know that when you have arthritis when you roll out of bed. And I always say that's my thing. You know how for spinal stenosis we say going up the stairs, pulling yourself up by the banister, and that. With the arthritis in your back, my thing is how are you rolling out of bed? Because if you're rolling out of bed with pain, you already know now you've got arthritis in your back. That's how I feel.
Yeah, you're right. Usually it's worse in the morning.
Yeah, and I'm over 2 years since my last radio frequency ablation. Knock on wood.
How many have you had total?
Oh, total.
3, I think. I don't know. I don't remember.
I've had them before. I think you though.
You did?
I think so. I don't know. I've had a lot done, so it's hard to remember it all. But no, I used to have to come in like it started off every 6 months, and then it went to a year. But it was like 6 months, 6 months, 6 months, a year, and now it's over 2. So it is a very awesome procedure. 2 weeks after it's done, it's like someone snaps their fingers and you're all better.
That's for you. Sometimes it takes up to a month.
Yeah.
Sometimes it's immediate. But that is an old time procedure. That's been around forever.
Right.
We've been doing that for over 20 years.
Oh, it works.
Yeah.
Yeah.
And thank God the insurance companies are still paying for it.
Sure.
And rightfully so, because they know it works.
Yeah.
And when a patient has less pain, they go to work more.
Right.
When they go to work, they're going to pay their insurance, their health insurance.
Right.
And the insurance companies make money that way.
Yeah, they like that.
But if they don't go to work and they have low back pain, the state has to pay for it.
Right.
So it's cost effective for everybody.
Yeah.
The insurance companies are still making a lot of money. That's it. It's
a hobby of theirs. Oh, we're 43 minutes in.
Yeah. So what else can we talk about today? This week was
we last show we were talking about cervical stuff, and we even got a patient come in because they heard our show when we were talking about the neck area.
What's weird about that is this patient that and this is why we do these shows.
Yeah.
This patient was already my patient, and when they come in through the door, the main thing he was concerned about was the low back pain and the sciatica pain down his leg.
Oh,
and we pretty much got rid of that, and he was back for a follow-up.
Oh.
And when we ask him, where's your pain? We don't specifically say, hey, you got any pain in your neck?
Right.
Where else you have pain?
Right, right.
We treat all pains. We don't work like that.
Yeah.
We ask you, where's your pain? And maybe we should ask more specific questions, because this guy was like, Doc, you mean you could help my neck pain and the pain going down my arms? And I said, why, is that what you have? He goes, yeah, I didn't know you treated that, but I listened to your show the other day. And I said, well, why didn't you tell us when we asked you where your pain was? Because my main pain was down my legs and in my back that you got rid of. And he goes, thank God I saw that show, because I would have walked out of here wondering who's going to fix my neck?
Who's going to fix my neck?
Pain down my arms.
Yeah.
He doesn't have an MRI. He was treated before, but they gave him just like oral prednisone or something, which is another good topic we should talk about.
Well, just one quick thing. Eileen says, "I'm so glad I can't." Her last name's Kirk. She says, Eileen Kirk. So just in case you know, I am so glad I came to you for my back pain. I'm seeing you again on March 1st.
It's Wednesday.
Wednesday. Oh, I'll be in the office too, Eileen. So keep an eye out for the big giant guy, and I'll give you a wave.
Yeah, he'll be in the kitchen.
Yeah,
in his office. Anyway, so we're going to treat this guy's neck. So we probably should get, and we give a piece of paper with a diagram, and with, you can take colored pencils if you want,
right,
to color in the diagram of the human body with dermatome distribution, which means we could tell you if you fill out a certain area in the body and it has a number on it, you could tell more or less what nerve is being pinched.
Yeah.
And if you just do the lower extremities and you don't do the upper, to us, you don't have pain there.
Yeah. Yeah.
So this guy's
color that thing in. Color that thing in with all your pain. I remember having to do that myself.
Yeah.
Yeah. But it's
the
a good
thing is, we had a patient yesterday.
Yeah.
That came in and said, "Doc, you gave me this injection, you gave me that injection, and I'm just as bad as I was when I came the first time.
Right.
What am I doing coming here?" I said, "Well, true. What are you doing coming here?"
Right.
And I get a little offended by that.
Yeah.
But then, very rarely you do stuff to patients and they don't get better. So what do? I asked the nurse to go into the chart and read to me the pain that the patient described in the waiting room before they saw me. And the patient had low back pain going down into both hips and radiating down, I think it was the right leg.
Yeah.
Now she just has a little bit of pain in the lower back. A pain score of about a 3. But I got the same pain. You never did anything. I said, "What happened to your pain down your leg?" She goes, "What do you mean my pain down the leg?"
Yeah, they don't remember.
They don't remember the pain that you get rid of. They only remember the pain you don't have.
When I was suffering pain, that was the nightmare of my life. No joke. I say that to everyone. It was the nightmare of my life. And what happens when you're it's a type of trauma as well, like the pain you've suffered, and then going through this healing process with you. What happens to a lot of people that went through a huge trauma? They forget about it. The brain wants to block it out and doesn't want you to remember it. And that's what happens with a lot of these patients, I think. Yeah.
So she kind of calmed down and it was more grateful at the end.
Sure.
Because then we showed her the picture that she fills out.
Yeah.
And it was, sure enough, it was shooting down the leg.
Right.
She was, "Well, oh yeah, now I remember." Now I remember. But
I mean, that in itself is a phenomenon, though. Like how the memory readjusts because it's protecting you from those bad memories.
Yeah.
Of that pain and all of that. It's probably part of how the brain deals with the memories of old pain.
With negative. Well, yeah, if a person's a positive person, usually they forget negative.
Yeah.
They try to isolate that from the brain. But sometimes you can't.
Yeah.
But the another topic came up was I'm going to put a second spacer in somebody in the spine for spinal stenosis. And they really didn't get too much better with the first spacer. And I tell them that don't get discouraged. In fact, I'm putting one in a friend of mine who's got 2 levels, but I'm doing it in the worst level. And I tell them that maybe in the beginning I didn't say this because I wasn't as experienced, when you're just putting them in.
Sure.
The spacers for the spinal stenosis. And I tell them, I said, "Listen, I don't want you to get discouraged if I put this one in and you come back in 3 weeks and you're still in the same pain."
Right.
Because I have different scenarios that happen. You have 2 bad levels. Sometimes patients come back with no more pain and we don't even have to do the second level. That's one of the main reasons we don't do both levels. Or you could come back with no significant change.
Right.
And you will not get it most likely until we do both levels. I've had patients with 4 bad levels. You do 1 level, they don't need any more.
Right.
And it's all subjective anyway. It's patient satisfaction.
Yeah.
I'm sure they still can't run a marathon, but
Right.
they can walk better, stand up straighter, and their legs are stronger. And they don't have to lean on a shopping cart maybe as much.
Yeah. Because everything else, it's kind of like if it ain't broke, don't fix it.
Yeah.
Yeah.
Of course, it has a lot to do with the fact that the insurance companies don't pay for the second level.
Right.
So the amount of money you got to pay for the prosthesis going in there, the spacer, you could never afford to do 2 at the same time because you would lose money and I'd have to take money out of my pocket.
Right.
And that's the way, for some reason, it's the way it's designed. And these CEOs of the insurance companies are very smart. They get paid millions and millions of dollars to figure these things out. So if they don't pay for a second level, think of how much money that they save. In other words, if they paid for the second level, there'd be more doctors operating on the second level. And there is a small percentage of patients that don't need the second level done.
Right.
So they save that money and it goes into the pockets of the CEOs. No, I'm just kidding. But they don't waste. Well, listen, they're smart and that's what they're being paid for.
Yeah.
They come up with some ridiculous things. Like, for example, when you do medial branch nerve blocks, right? The old days, I had a patient yesterday who had a lot of patients yesterday because yesterday was a day I had 30 patients, and I got all walks of life coming in with every topic we talk about, and that was why I remember them because they were yesterday.
Yeah.
Patient had 5 levels, maybe 6 levels of arthritis in the spine.
Oh.
The insurance companies only let us treat basically 2 levels. If you got 2 levels treated and you got 5, 6 levels that are bad, you're not going to feel any better.
Right.
But I explained to the patients that they only let us do those 2 levels. It's 3 nerves on each side, and it's only treating 2 levels. And I tell them in the beginning, you might not feel any better because you got problems above. You got arthritis above. And what we do is once we do this, if you don't get any better or not significantly enough, then we do the upper levels and you're good.
Right.
That's one thing that's weird because the old days, if you had 5 bad levels of arthritis and you had the clinical symptoms, worse in the morning, get from a sitting position, standing up, it hurts, you stretch your back, different symptoms that you get to be able to prove you got pain from the arthritis. Right. As soon as you start walking, it starts to loosen up and get better. Then if you walk too much, it gets worse. These are the symptoms. You can diagnose it. You look at the MRI, you can see it. CAT scan, whatever. X-rays, you can see it.
Right.
Very easy to diagnose. We used to just do the ablation on every level. Patients came back most of the time close to 100% pain-free. Today, you're only allowed to do the bottom levels. And when you do it, before you do it, you have to numb the nerves. So you got to go through a test. And then once you go through the test in the recovery room, they got to be 80 to 100% better, or they don't pass the test and they can't have it done. Right now, if you got somebody with 5 or 6 levels that are bad, you're only testing 3 nerves at 2 levels. How are they going to be 100% pain-free? They're not. Right. So that's ineffective. Number 2, you got a patient. These patients, they want you to come back a second time in 2 weeks to do the same test again with a different numbing medication. To me, that's a total waste of time.
Right.
If you pass that, then you can go to the ablation. Right? Now, I have my own theory on why they do that.
I'd like to hear that. Yeah.
Well, the theory is, as far as I'm concerned, and it happened a couple of weeks ago.
Yeah.
The patient says, I'm not going through dosage 3 visits with 6, 6, 12, 18 injections.
Right.
I hope my math was right.
Yeah.
18 injections.
Right.
In like 3, 6 in 6 weeks. At 6 weeks, I'm not going to feel better for maybe a month after. Forget it. I'm not going through that. Guess what they just saved? A lot of money.
Yeah.
So they figure out how many people will drop out.
How many people are going to get burned out by it and just forget it?
Not even start it.
Oh my God.
I don't know what the percentage of people that do that, but they figure it out. They can figure it out easy now. They figure out how many people backed out. So if they have to do the extra test, Listen, I'm not complaining about the first test.
Right.
First test, it's cool. Patient's like, oh, yeah, this is how I'm going to feel. Great, let's do it. So it kind of gives a stimulus to the patient.
Sure.
But then I got to tell the patient you got to do it again. I just did it. What are you talking about?
It doesn't make sense.
To me, that's a waste of time.
Yeah, yeah.
But because of that,
Yeah.
patient doesn't go ahead with it. That's what even though they pay an extra procedure, ultimately they're making more money. They're not losing more money. They're spending less money of the patient's money because they're the ones buying the insurance.
Yeah.
Well, we've always talked about this kind of stuff. What time is it?
Yeah, we're pretty much done.
Yeah, pretty much done. I heard Dr. Schneider, I heard her walk in.
Oh, the amazing Dr. Schneider. She's on next with Radio Free America with Dr. Barbara Schneider.
That's great. All right, everybody. Listen, give us a call at 732-262-0700. We're at 74 Brick Boulevard, Brick, New Jersey, behind the Roy Rogers, across the street from Burlington Coat Factory Stop and Shop, right at the border of Toms River and Bricktown. So if you're from Toms River, it's not a long ride. I had a patient yesterday, I had to sign papers.
Yeah.
It's going to a different doctor because they're too far away. Guess where they are?
Where?
Manchester.
Oh, come on.
Are you kidding me? It's a 15 minute ride.
It's just down 70. Come on.
Too far. But that same person would drive up to Newark to get a haircut.
That's nuts. That's nuts. You're right, too.
Well, if it's a woman,
you're right.
They drive to Jersey City to get their hair done.
Go to Bayonne. No, I got a guy in Bayonne.
All right. So you can get us also at our website.
Yeah, that's jaspermd.com. And please make an appointment by calling 732-262-0700.
And by the way, you can see this on YouTube.
Yeah, YouTube.
If you missed it, if you got somebody you want to show.
YouTube, iTunes, Yahoo, anywhere podcasts are found, you'll be able to find this. And of course, tomorrow morning on 104.1 FM on Cat Country Radio, you'll be able to hear these. It's a 2-hour block we've got, so it's from 6 to 7, 7 to 8. Yeah. So the whole morning is
so you got nothing to do Sunday morning. You don't want to sleep in, you can watch it.
Yeah. And you'll hear this very show tomorrow.
Thank you very much.